Fascia is really unusual in that it's in the immediate environment of every cell in the body. It forms the interstices. It's like the platform or the framework for support of the body.
So maybe just mention what interstices means. So basically we have cells, which most people will be familiar with.
Yeah.
And inter kind of just means between the cells.
Yeah. Stices are spaces.
Spaces.
Between the cells, yeah.
Hello and welcome to another episode of CMTV. I'm Aubrey.
And I'm Alison.
So today we're going to be talking about a few different topics. Ali, what were you going to be talking about?
I'd like to talk about the difference between cellulite or stuck fascia.
A very common problem. So a lot of people will, I think, assume they have cellulite. Mm-hmm. And you reckon a lot of it is probably just stuck fascia?
Yeah. So we just want to have a little look at what fascia is, because maybe it's not in a lot of people's awareness apart from body workers, and what cellulite is, and just the correlation and the crossover and how to discern which is which.
Awesome. Sounds good. So I'm really going to be talking about common patterns of dysfunction in the lower leg, because again, I think there's a bit of a mismatch between what I see in a lot of textbooks and what I see in clinic. So I'm going to talk about what I see as common patterns of dysfunction in the lower limb that'll affect most people, but like sports people, runners in particular, I think it's going to be quite a big one. So we're going to talk about that. And if we get time, I'd like to talk a little bit about kind of different noises, things that go bump in the night, different kind of cricks, cracks, crunches and stuff like that in the body. What most people think of crepitus. Yeah.
Sure.
So do you want to start, or will I begin with the lower limb stuff?
Yeah, I'll go ahead. I think from being in clinic and from teaching classes, we assume that people have a certain working knowledge of the structures within the body. And time again, we find out they've never heard of it.
Yeah, not just the public, even talking to fellow students in class, you'd say something and they've never heard of it, things that we kind of take for granted.
Yeah, exactly. So just a quick overview of what fascia is. So fascia is classed as a connective tissue, and that includes everything from blood to bone. They have the three elements, the cells, the fibers and ground substance. So I think most people might be familiar with connective tissue to some extent.
Yeah.
Fascia is really unusual in that it's in the immediate environment of every cell in the body. It forms the interstices. It's like the platform or the framework for support of the body.
So maybe just mention what interstices means. So basically we have cells, which most people will be familiar with.
Yeah.
And inter kind of just means between the cells.
Yeah. Stices are spaces.
Spaces.
Between the cells, Yeah, so that lattice provides a support for the cells. So it's in the immediate environment of every cell. Sometimes it's described as a three-dimensional web, a support for the soft tissues of the body. So really, really important tissue, and yet not that well understood and largely ignored until the first Fascial Congress.
Yeah. 2007. They're generally every 3 years. Trying to think when the next one is.
Lots of interesting.
We might put that in our show notes.
Yeah.
But there's been an awful lot of research that has come out over that time, stuff that has completely flipped on its head what was previously thought about fascia. So there's been a lot of developments in that short period of time. And I think a lot of body workers are going to be aware of fascia, but maybe not some of the detail, and certainly the public aren't going to be as aware.
Yeah, exactly. They might have heard of the fascia on their house, but they didn't realise that fascia is a tissue within the body, the connective tissue, as we mentioned. So it's at different layers within the body and different densities within the body. We've superficial fascia just under the skin. We have the fascia around muscle, myofascia. Some body workers will be aware of myofascial release. And then we have the subserous, the stuff lining the cavities of the body. So different thicknesses, different layers weaving its way throughout the body. We mentioned that there's cells, fibers and ground substance. Of particular importance, I think, are the collagen fibers within fascia. They have an ability to cross-link. And I'm quite interested in the things that encourage them to cross-link or get sticky as such. One of the things that's really relevant is sugar and refined carbohydrates. So pasta, shop bought bread, things like that. They refined or ultra processed food really start sticking the collagen fibers.
I was watching a podcast recently and they were talking about that. It was somebody in the UK, professor of something, and they were saying that really most breads, because of the way they're now produced, could be really classed as ultra-processed food. Like stuff you're baking yourself at home is going to be different, but they said most bread that you'll buy in the supermarket, because of the types of ingredients they're using. And you would always think of bread as a fairly basic food stuff.
Yeah.
And to think of that as ultra-processed was a bit shocking.
Yeah. Well, I guess the person making the flour might refine it and bleach it and have anti-caking agents. And then the baker says there's flour. So, you know, there's a lot of issues, I think, around labelling and yes, and not always as obvious. But I think the effects of sugar on the diet are just astronomical in terms of how much sugar is now consumed, and that it's really in so many things that, again, hidden. We're not maybe aware that it's in such high quantities in food.
Yeah.
But sugar does tend to make the collagen fibers stick together, cause this cross-linking, and this can make the fascia more sticky.
Yeah.
I think along with that is being immobile, just sitting for long periods of time, that people might get really involved in what they're working on and might be sat in front of a screen for 3 or 4 hours before they even move a muscle. So even setting a timer and getting up after an hour and walking around really helps. In terms of cellulite or stuck fascia, I've seen a lot of women in the clinic kind of going, oh, my dimply skin and it's bumpy and it's unsightly and drives me crazy. And I hate when it comes into summer and I have to, you know, show my legs or get into a swimsuit.
Yeah, surprising the number of young people even where the fashion is towards leggings at the moment. And you'll sometimes see that skin irregularity even through the leggings.
Yeah.
Like it's a very common thing.
Absolutely. So again, there's lifestyle issues in terms of diet and activity, and for women, hormonal influences in terms of the estrogen receptors on the fibroblasts, the cells that produce the collagen, can impact the quality of collagen that's made.
Okay.
So in menopause, the collagen is more brittle and loses some of its suppleness and elasticity, and that can lead to sagging skin and more aged experience. So there's particular things that can improve the quality of collagen in the body. I know it's really popular taking hydrolyzed collagen at the moment, so it's like amino acid with collagen, but the body will just break that down into amino acids again. So I think eating the foods that the body needs to make good quality collagen and reducing the foods that cause the collagen to adhere, it's really relevant.
Yeah.
So such foods that increase collagen production, vitamin C. Vitamin C really important for good quality collagen.
Makes the collagen have good kind of tensile strength, so it's less likely to break, but you think maybe less likely to stick?
Yes.
Even the term sticky is kind of interesting because it's kind of a subjective thing.
Yes. And I'm going by what I feel in the tissue textures when I'm working with clients in the clinic.
Yeah.
So some clients just feel like they have sticky fascia. It adheres really easily. But the good news for them is that they respond really well to body work because it frees up equally quickly with the tissue, with the techniques like the cups. Yeah. So I tend to use the silicone vacuum cups to lift the superficial fascia.
There's a whole area of debate over which types of cups are best. Really, they all create vacuum.
Yes.
So what I've found teaching various styles of cupping is people tend to have a preference for the one they learn first.
Yes.
So let us know in the comments. I'm sure we'll hear all kinds of opinions. I like the silicone too.
Yeah, they're really easy to use. I mean, literally a little bit of lubricant on the skin, some even a moisturizer, and you can get a pretty good seal and lift the tissues and then move them up and down. I recommend following a pattern similar to skin brushing, that you're drawing tissue fluid and lymphatics towards the nearest nodes, and it gives an indication of where the watersheds are and the direction that things move more naturally. But just back briefly to diet, things that are going to promote good quality collagen. So they say particular amino acids, particularly glycine and proline. They're in things like meat and I had a few notes here.
Sometimes talk about things like bone broth and stuff like that.
Yes.
That'd be good.
Yeah, bone broth is going to encourage.
Obviously not suitable for the vegetarians and vegans, but
collagen
for those
production.
who are eating meat,
Yeah.
good.
So foods high in vitamin C, obviously, the amino acids, particularly those two, it's in things like cabbage, mushrooms, unusual foods that you might necessarily associate being good for collagen production, and then zinc and copper. So oysters, a good source of zinc. And your dark green leafy vegetables. But I think having good levels of vitamin C would be a top priority, and then avoiding things that tend to congest and clog the body. We mentioned the ultra processed food, but I think in particular things like pasta. If you leave pasta in a pot and you see how solid it goes, I just feel that if you have a slower metabolism and you're not moving as much, you're not burning the carbs.
Yeah, so not to say that pasta isn't, you shouldn't eat pasta.
Yeah.
But if you're more prone to that kind of, we're calling sticky fascia for simple terms.
Yeah.
That might not be suitable for you, or certainly the quantities. I experimented with this in my late teens, and I tried eating pasta, I think 3 times a week, and I felt that limited range of motion, that feeling of being stuck in your own body.
Dodgy.
And I cut it out. It reversed really quickly.
Yeah.
I started eating pasta once a week, I was fine. Twice a week, I was okay. Once I had 3 times a week, I started to feel that tissue getting stuck.
Yeah.
So that's interesting because, that's obviously going to be different for different people. That was my personal experience.
Yeah.
And sometimes you got to do a little bit of trial and error, but some people might be better off nearly avoiding it altogether, and other people get by with a couple of times a week. And probably the quality of the pasta as well, how it's produced.
Exactly.
The
makes a big difference.
simpler, the closer, a bit like the homemade bread.
Yeah.
The better, yeah.
If you make it yourself, it's going to be a lot better. You know what's gone into it. Yeah, so in terms of body work, what I'm feeling for is what are the texture of the tissues. So it feels like nearly bubble wrap inserted under the skin. So they talk about cellulite being these fibrous cords that tether the skin to the muscle. And because we have an adipose layer, a fat layer, that then protrudes in different sections, giving an orange peel effect. But these fibrous cords are fascia.
Yeah.
And I think in the early stages, if we can free up the fascia, creating something like a vacuum using the cups, we tend to free those adhesions. Those hydrogen bonds can break quite easily. I think over time, they tighten, they shrink, and they get really adhered and stuck.
Yeah.
Even if it's very stuck, I think working the tissues with skin rolling techniques, sustained stretching, the cupping, and then improving the diet, walking, skin brushing and things like that. There's an awful lot you can do to improve the condition.
We see various stages of that both in clinic but in class as well, that oftentimes when you push into the tissues, you'll see the orange peel, that it's not there at rest.
Yes.
But presumably then as it gets more severe,
Yeah.
that's when it starts to be visible, even when you're not pushing on the body, you're not like dimpling the tissues with your pressure.
Exactly.
Okay, interesting. Because I've definitely found that when you press in and you see that dimpling effect, I think we have a little clip on this that we might actually put in, that the skin looks smooth and then you create some pressure or draw or movement, or you're pushing in and you see this bumpiness to the tissue.
Yeah, that
kind of
undulation.
sticking in. Yeah.
Yeah.
Almost, I always think of it as like something clumping. So you have like thick bits and then the next bit is thin and then thick and thin. So you get this corrugation nearly.
Yeah. Yeah. So don't lose faith. There's lots of things you can try out to get improvement, whether it's stuck fascia or cellulite. Body work and improving diet are going to have a big impact.
Yeah, awesome. So that's definitely an interesting one. And before we leave it with the cups, the other type for the public that maybe they're not therapists and aren't familiar with the different styles of cups, the other, I suppose, popular type would be the gun that creates vacuum. They're perfectly good before people start complaining that the gun is better. You can use that gun to create, it basically has a hose and it pulls air out and it creates a vacuum. And then the more traditional type would be like fire cupping, but obviously there's risks associated with that. For those of you who do fire cupping, that's fine. If you're well trained, that's great.
Yeah.
Anything that's going to create vacuum is basically going to do the same job.
Yeah, absolutely.
Great.
Yeah.
Okay, well, I might talk a little bit then about what I see as kind of common patterns of dysfunction in the lower leg. And I've got a slightly contentious opinion on this, and there's a little bit of nuance to be followed. So what we usually find is, we did this in our Essential 8, we talked about like commonly dysfunctional muscles in each part of the body. And for the lower leg and foot, anything below the knee, I always think posterior tibialis is a big contributor to a whole range of conditions. But when we talk about kind of structure, and particularly in relation to running and how it's going to influence how the bones are sitting, that's what I mean by structure. A posterior tib dysfunction, when the person is not weight bearing, you'll oftentimes see this. If you get the person lying face down, you bend the knee and you look at how the foot sits. The tighter the calf muscles are, the more plantar flexed it's going to be.
Toes are going to be pointing towards the ceiling.
Yeah.
They nearly look like they're on point, like a ballerina.
Yeah. In some cases, nearly that extreme at rest. But then if posterior tib is particularly tight, the foot is not only going to be plantar flexed, it's going to be inverted. So it looks like the foot is rolled in. And when you see that, you see this posterior tib dysfunction. Now we think of that as short and tight. And this confuses people because when you're weight bearing, it's more common to see people with a low arch than a normal arch or even a high arch.
Yes.
So high arches do occur, but they're less common. The normal arch is kind of rare-ish. Certainly when we do postural assessments in class, I would say probably anywhere from 60 to 80% of a group will have a tendency to a slightly low arch or quite a low arch. We don't really tend to see flat feet that much, but a lower arch, what they call hyperpronation. And you see this a lot in running as well. It's a big thing. They oftentimes talk about putting in a support or a lift. And I just wanted to talk about how I think that process occurs. That when posterior tibialis gets dysfunctional, it will be obviously short when it's not weight bearing. But when you're standing, the weight of the body tends to stretch it out. So I don't know that it's fully stuck in a shortened position. I think oftentimes it's actually more stuck mid-range, but it means it's not able to really lengthen or shorten properly. It can't do its job. It only has a limited range within what it should be capable of doing. And as a result, it's not actually able to support the arch properly. But I think the big factor is when it gets tight, one of the bones, the talus here underneath the tibia, between really the tibia and the fibula, it gets shunted forward in that plantar flex position. And then as you go to walk, if this is not far enough back, the tibia hits the talus, and our pattern then is we tend to crumple, we tend to push down on the arch. So we get this collapsing of the arch as we try to walk forward.
Yeah.
And I mean, that's obviously going to be pronounced if you're running, you're doing a lot more steps, or you're just doing a lot of walking. The more activity you're doing, the more it's going to collapse that down. It's not to say the activity isn't good, it's great, but it may be highlighting a dysfunction that otherwise might go unnoticed in the general population. So when the arch drops and we get this what's called hyperpronation, most people will tell you the tibia turns in. This model is pinned, so if I was to do that, the tibia does actually rotate in slightly. But what I see in clinic is actually that as the arch goes down, the knee goes inwards towards the center line, what would be referred to as a valgus deviation, which is basically movement of the joint towards the center of the body, towards the midline. It's the easiest way to think of this. And when the person gets that, if we want to use simple terms, we might say they'd be knock-kneed.
Yes.
That's what most people are going to relate to it as. So you get this hyperpronation, the knees drift inwards, but as a result, the tibia and the fibula actually externally rotate.
Yeah.
So it's actually a bit of a twist. Now, you tend to see this, you'll see different things, whether the person is weight bearing or lying down. Now, we talk about this all the time when we're doing assessments because each assessment will have its critics. And I would say the point is any one assessment is not giving you the full picture. You see different things weight bearing, you see different things when the person's lying down. Both are providing you with valuable information, even if it seems contradictory. I was talking to another therapist about this recently. We were talking about a fairly small obscure muscle in the back of the knee called popliteus. And popliteus basically, when your leg is fully extended, your knee is kind of locked out. Popliteus's main job is just to take you out of lock.
Yeah.
Now, when you sit down, that muscle is going to be shortened. When you stand up, it's stretched. So when you think about that, it's basically turning the tibia in.
Yes.
So when we talk about the person lying down and you bend the knee, popliteus is taken out of the equation, and you'll more obviously see that the foot and the tibia are turned out.
Yeah.
Now, we did a video on this. We'll share a link in the show notes. It's on YouTube about the anatomy around talar dysfunction, but it kind of talks about some of these elements. So when you assess in that position, it's more obvious. When the person is standing up and the leg straightens out, popliteus now engages and it takes out some of that rotation. You'll see this when you see people running, because when the foot falls, the leg is pretty straight. When they go to stride, you'll see the foot kicks out. It's that very obvious kind of like, it looks slightly bandy-legged, to use an uncomplimentary term. Sometimes you'll just see it on one leg. We tend to see this on guys more. In women, because of the different Q angle, we tend to see it a little bit more pronounced.
Yeah.
Not always, not all the time. That's not that gender specific, but you do see a little bit more of a prevalence that way. So what I would say is that kind of hyperpronation causes this rotation in the knee, which causes the bones to no longer be properly aligned. So like here we can see the meniscus, which is this kind of cartilage in the knee. It's kind of a cushiony sort of cartilage, but it basically, I always think of this as like a double egg cup, because the end of the femur, these condyles, could be seen as almost like the two eggs. And when the knee joint is aligned properly, the weight comes down evenly. It's spread. You guys can try this yourselves watching the video. That I always use the analogy of like using your knuckles. If you put your knuckles together and they kind of interlock like that and you press against them, the weight is evenly distributed, no problem. Twist one fist. So they're not aligned properly and pressed down. And if the knuckles kind of pop off each other, it pinches the skin. It's uncomfortable. So if the knee is not lined up properly, that same pinch occurs. That pressure comes onto one point of the meniscus. And this is really, I think, one of the most common things that causes meniscal tears. I mean, you can have trauma and other things, but that misalignment is really going to contribute to tears in the meniscus and cause all kinds of knee pain, tensions, ligaments, affects the patellar tracking. There's a whole host of things.
More obvious with the knee bend, maybe?
Yeah.
Yeah.
But my point would be, it comes very early on.
Yes.
Remember, we started this discussion with posterior tibialis not working properly, then affects the talus, which affects the arch, which causes the rotation, which causes that pressure in the knee.
Yeah.
The contentious part, I would say, is most people will say the tibia rolls in when the arch drops. I think the tibia actually rolls out, because that's what we tend to see in clinic. Let me know what you guys see in the comments. Watch people running as well and see how common that is for the leg to kind of kick out. And that would be another indicator that there is maybe this pattern. So we could assess the client and see, standing, do they have a low arch? What way is the foot sitting? What way does the knee look? When they're on the table and we bend the knee and we relax popliteus, now how does the foot sit? Is the tibial rotation more obvious? So we're looking at kind of, because the mechanics will change depending on the position of the body and whether or not it's load bearing, you need to assess each of those things, recognize the common pattern, and deal with the underlying cause, which is really treating posterior tibialis. Once that's corrected, we can move the talus back. That can help then when we start to actually do the strengthening exercises, because most people try and add the strengthening before they've corrected the joint dysfunction. Yeah. And it's not that successful. If we can do that, and we get them strengthening up, then we can look at what's going on with the knee. And there's another muscle in our essential 8, the short head of bicep femoris, one of our hamstrings, that really gets in on the act as well. And it increases that tendency for the tibia to turn out. Yeah. So addressing those can really be quite successful in knee pain.
Yeah. And even just the perspective of seeing is the point of the kneecap lined up with the tibial tuberosity. That could give an indication when the leg is relaxed to see what the alignment is like there, and asking, do you have pain going upstairs or coming downstairs? So sometimes people will say, I'm fine on a flat surface. It's the stairs that give me the greatest issue. And then even isolating it to going up or going downstairs. Sometimes I'll have clients sidestep down the stairs while we're doing the work on the knee, just not to irritate the structures as we're getting the alignment back.
Yeah, taping is really good for that as well. We oftentimes use that as an example in a class when we're taping the knee. We'll usually get the person who says that I've got pain maybe going down the stairs, which is the earlier stage. It's more common. We'll put on one piece of tape, get them to go up and down the stairs, put on a second, a third. And usually by about the third piece of tape, they start to notice, oh, I can go up and down the stairs without pain. Certainly by the time, if you need to add a fourth piece, they usually feel rock solid at that stage. So just interesting how those things are affected by proprioception and joint alignment and
all the factors that feed into it. And then even the different sounds that they describe, like are they feeling, what are they feeling and hearing? Yes.
So that kind of moves me on to the second point. The second thing that I want to talk about today was what I would call cricks, cracks, and pops. So really, these are different kind of sounds that we'll hear in joints, and there's kind of misconceptions around each one. So looking at pops, first of all, that this would be like when you crack your joint. There's a lot of misconception around this. This is usually referred to as a cavitation. You'll oftentimes see videos in social media about chiropractors adjusting people and you hear this crack, crack, crack. So a lot of that is simply called a cavitation. Now, the cavitation occurs when a joint has been kind of compressed or compacted. It can happen anyway, but as you create a sudden increase in the joint space, the gases that are in solution fall out of solution and in the process form a bubble. And it is the formation of the bubble that makes the noise. So initially when people started to talk about this bubble formation, they said, oh, pressing back in collapses the bubble and that's what makes it go. I might be able to do this if you can hear this. If you don't like the sounds of joints popping, close your ears or mute the sound for a second. As I pull the joint, I'm not going to let it go back. I'm just going to pull and it pops while it's stretched out. I haven't pushed back yet. If I push back, no sound. So it is the formation that causes that audible sound.
And it won't happen immediately.
It won't happen again. And that's how you know it's a cavitation, because once the pressure has changed and the gases have fallen out of solution, it takes about 30 minutes for those gases to slowly go back into solution. So once you pop the joint, you can't do it again for a certain period of time. So when a joint pops like that, it's not good, not bad. There was a Dr. Unger who, as a kid, was told, oh, don't crack your knuckles, you'll get arthritis. And as a child, I think he was 5 or 6, he had that scientific approach that he went, oh, really? I'm going to put that to the test. And he consistently, every day, cracked the knuckles on, I think, his left hand and never cracked his right hand. And now in his mid to late 60s, he said he actually has slightly better movement, less joint discomfort in the hand that he's always cracked compared to the hand that he never cracked. So that is an old wives' tale. Not true. Cracking your joints doesn't give you arthritis. So if anything, it actually increases joint space. It's useful. In terms of therapy, I always say whether a joint pops or not really doesn't matter. I would use it as a confirmation. If a joint was stuck and you hear a pop, you go, well, a joint that wasn't moving has started moving a bit better, or at least we've gotten a cavitation. It's not good. It's not bad. Sometimes joints will move and they don't cavitate. So it's not really that relevant one way or the other.
Yeah.
The impression we're given is, the cracking is the important bit. And it's like, no, it's getting the joint movement back where it was lost or reduced is important.
And even the joint space so that the synovial fluid can nourish the cartilage.
Yeah, that we're not getting early breakdown of cartilage and it's not getting a chance to repair because it's simply not getting its nutrients and oxygen from the synovial fluid.
Yeah.
So we put a short link to this. There's a very good video. They actually did an video x-ray of this process of popping. So we might put a link to that in the show notes as well. So be sure and check the show notes while you're liking, subscribing, and maybe commenting on this episode as well. So the other thing then was joint cricks. So this is where the joint kind of like, most people would be familiar with this with their knees when they bend down, they get this kind of grinding. That's really crepitus where they talk about. Crepitus is like, if you think about walking on fresh snow, there's this kind of crunchy, slight creak that people will be familiar with. Unfortunately, a lot of people will be with their knees. And I always think that's when there is compression of the joint, or with the kneecap is being pulled in against the femur. And basically, collagen is creaking against collagen. It's not gliding because there's too much tension, either from that kind of malalignment or patellar tracking issues if we're talking about the knee, which incidentally is much more down to the tibial rotation than it is down to quad muscle strength. People always say lateral musculature, the vastus lateralis is tight, medialis is weak. That is true, but it's not as big an influencer on patellar position as the tibial position. If the tibia rotates out, it totally drags the patella with it.
Yeah.
So that kind of cricking is more kind of like cartilage grinding. And so we'd want to relax the muscles and restore joint space. But then the last one is more the cracking, the kind of snap. People will talk about like clicky hip and things like that. So that's either a ligament or a tendon flipping over a bony prominence. And it's different to popping your joints, because we said once a joint is popped, it won't pop again. Whereas somebody with clicky hip, they'll lift and drop and lift and drop. And every time, like repetition after repetition, it'll just click, 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 click.
The same point.
Yeah. So that's not a cavitation. So why are tendons or ligaments snapping over bony prominences? Well, with tendons, the associated muscle is too short and tight. So the tendon catches, tension builds, and then it flips over the bone. And then when you move back the other way, it slides back over and then it flips over again. So muscle tension would be responsible there, and we would want to normalize the tone. And so take pressure off the tendon so it can now slide over the bone instead of snapping. With ligaments can be tensioned as well, but the process is different because there isn't something pulling on them the way there would be muscle pulling on tendon. Usually ligaments will get taut like that because of joint misalignment. So we're back to the same problem. So if joints are lacking centration, basically if the bone is not in its ideal place. So we're not talking about dislocation, where the contact surfaces are no longer together. We're not talking about subluxation, where it's kind of half out. We're talking about it just not being in its ideal position. If the joint is not in its ideal position, let's say the femur is slightly rotated, some of those ligaments are going to be tensioned.
Yeah.
Because when a joint is in a neutral position, ligaments are kind of lax. They really only engage as we get towards to our end range, because muscles are primary stabilizers, ligaments are secondary stabilizers. So if a joint is not in its right position, it's kind of pre-tension that ligament. And so now, because again, it's tight like the tendon, it can snap back and forth over the bone. So anytime we get kind of clicky hip, we would want to try and normalize the tone of the muscles crossing that joint and then get the joint back in its centric position. Because then we're going to deal with whether it's a tendon snapping or a ligament snapping, you're going to have corrected the issue.
Yeah.
Obviously, we can tell the difference through assessment. If we have training in detailed assessment, we can do active, passive and resisted tests, muscle length tests and so on, and determine, is it more tendon or is it more ligament? But in either case, treatment is really going to be the same.
Yeah.
Because a joint is only going to lack centration because some of the muscles crossing it are tight and some are weak.
Yeah.
So we kind of got to treat the muscles first, and then we've got to bring the joint back to its ideal position. And if we do both of those, the clicking should go.
Like A.T. Still said, roll the bones and they'll come home.
Yes, A.T. Still, father of modern day osteopathy. And I always like those little kind of sayings. And sometimes people go, what, roll the bones? Like they're thinking of, rolling dice. But I always think of it as, if you create space and motion, the surrounding tissue tension will oftentimes help bones to move back to their ideal position.
Yeah.
So roll the bones, create space and motion, and they'll come home. Tissue tension should bring them back to their ideal position.
Yeah.
That's my take on it. That's how I would interpret what A.T. Still said 125 years ago.
Yeah. It's a while ago now.
Yeah. Some great ancient wisdom out there.
Holds true.
Yeah. Anything else to add to that?
No, I think it's interesting because how your client describes their condition, sometimes they use words that you're kind of going, yeah, that's not a thing.
Yeah.
But it means something to them. So kind of giving them the language to describe what it is. Like if it's nerve, oh, is it electrical? Is it shooting? Is it, burning, pins and needles? Yeah. Like sometimes say, oh, it's like water flowing down my limb. And I'm like, okay. I'm just kind of saying, are they feeling a warm feeling? Are they feeling,
I think what's interesting with nerve stuff is they'll oftentimes use what I would describe as kinetic terms.
Yeah.
Things that you would associate with movement. They're very dynamic, like shooting, darting, stabbing, burning maybe to a certain extent. But it all sounds very motion orientated.
Yeah. It's traveling.
Yeah. And even the, cool water.
Yeah.
I mean, that could be circulation, it could be lymphatic, but again, it's kind of describing motion.
Yes.
Whereas people will say, I've got an ache, I've got a pain.
Yeah.
When it's more localized, when it's not neurological,
Yeah.
when it's maybe soft tissue or
stiff, I can't bend, it's stuck, it's catching me.
Yeah.
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 Yeah. Or I've got this pain right there and it's deep, or it's sometimes they'll say sharp.
Yeah.
But even that I wouldn't consider to be as movement sounding.
Yes.
Yeah. Yeah.
So it's always interesting to listen to the client and to inform them and give them terminology or an explanation of why they're feeling or hearing things.
Yeah, and share language, like the terms that might make sense to a therapist, but also then obviously respect their subjective interpretation and try and unravel the story as you talk to them, and oftentimes then things will make sense. They don't have the vocabulary always, so they're using terms that make sense to them.
Mm-hmm. Exactly. Yeah.
I was talking to one of my friends about a guitar, and I was saying, one of the strings is making a funny noise, and I was going, it sounds soapy. He was going, soapy. And the term I was trying to think of was a kind of squeak.
Yes.
And I don't know what the association was, squeaky clean or something. I don't know. But he was like, what's soapy? That makes no sense in relation to the sound a guitar string might make.
Yeah.
So it made me respect clients and what they might use as their own subjective terms to describe what they're experiencing.
But once you give them the explanation, they go, oh, that's exactly it. That makes perfect sense.
Yeah. And particularly during treatment when they feel it and they go, oh, yeah. There is that just literally putting words on the sensation. They know what they're feeling.
Yeah. But even telling them when we're maybe doing some cupping, it's like, can you feel that there? That feels like bubble wrap under the skin. And after going over it a few times and maybe bringing in some movement while you're moving the cups, and you go, can you feel that that's now smooth, that bubble wrap sensation has gone? And it's really getting them back into their own body and feeling the changes that the therapy is bringing about for them.
Yeah.
Yeah, really
Excellent.
good stuff.
Good. Okay. Anything else you want to touch on before we close out?
I think that's good for today.
Okay. So again, folks, if you enjoyed this, don't forget to like and subscribe and give us comments. We've had a ton of comments in since some of our earlier episodes, and we're responding to those. Some of what we talked about today was actually inspired by questions that have been asked by people emailing in or commenting on the video. So do comment. We do watch them. We will have a look and we will try and get to all of your different questions over the course of this season.
Absolutely. Look forward to seeing you next time.
Thanks for watching, guys. Take care.